I'm Dr. Venugopal, Director and Lead Consultant in Emergency Medicine, and I also the Chairman EMS Division in Society for Emergency Medicine in India. Today, I'm going to talk about the Toxidrome approach in emergency medical services. So why we want to talk about this Toxidrome approach? First of all, a large number of toxins are present, and all this has complex presentation, and it is really confuse the person who approach such cases. And also, there are many clinical conditions which mimics that overdoses. So every EMS personnel should have a basic understanding about the overdoses and its presentation. So what is meant by this toxidrome? A toxidrome, like every overdoses will present clinically with signs and symptoms. And through the signs and symptoms, you are getting, you are derived what kind of toxin is consumed. And that kind of approach is called a toxidrome approach. So what are the major toxidromes you know? There are many presentations, but the major toxidromes are: one is anticholinergic presentation, second one sympathomimetics and withdrawals, the third one opiate and sedatives, the fourth one cholinergics and anticholinergic esterases. What are the agents coming under anticholinergics? Anticholinergics include antidepressant, atropine, antihistamine, psychotic, antispasmodic, anticonvulsants, like carbamazine. This you can remember with the 6A. Definitely the Jimson seed also will cause similar kind of presentation. So how this anticholinergic toxidrome is present clinically? It will cause hypothermia, dilated pupil or mydriasis, dry skin, vasodilatation, then agitation and hallucination, tachycardia, and possibly dysarrhythmias. This will this jargon to remember. Anticholinergic toxidromes are very famous. That's a mad as a hat, hater, blind as a bat, red as a beet, hot as a hair, and dry as a bone. And the pre-hospital care treatment for overdoses include, definitely you have to focus on your safety and rapid transport, oxygen if required, administer oxygen if required, establish cardiac monitoring, and also staying alert for complications such as vomiting, seizures, and violent behavior. And coming in the hospital, continue the supportive measures, and rarely, sometimes you administer an antidote. The antidote is the FISOS treatment. The second, toxidrome is sympathomimetic. Sympathomimetics is something which mimic that simulated nervous system effects. And this alcohol and drug withdrawals also present a similar way. So they are also classified under this toxidrome. There are various agents which will cause sympathomimetic effects, including ecstasy, amphetamine, theophylline, caffeine, and cocaine. You can be easily remember this with eat coffee and cake. So how does the sympathomimetic toxidrome will present? This also, again, you can remember just remembering MAS. MAS means mydriasis, A for agitation, arrhythmia, and angina, T for tachycardia, H for hypertension and hypothermia, and S for seizures and sweating. And while managing these cases, remember the mainstay management is management of hypertension and seizures, particularly using benzodiazepines. And remember, avoid beta blockers in the treatment because it will cause an unopposed agonism. So here, when looking into the anticholinergic and the sympathomimetic, there are few similarities between these two. Like both these cases are present with altered mental status, agitation, and dilated people. But the differences between anticholinergic and sympathomimetic toxidrome are anticholinergic present with a dry skin, but the sympathomimetic with a wet skin. And the GI tract will cause hypoactive in anticholinergic, but the other side, it is hyperactive. There will be urinary retention in anticholinergic, but there is no urinary retention in sympathomimetics. And the next toxidromes come is opioids. They are the mu receptor agonists. Opioids include morphine, pethidine, fentanyl, codeine, methadone, then hydromorphone, etc. Hydromorphone, etc. And also like the partial agonists like buprenorphine and pentazocine. These opioid overdose will present either with CNS, both CNS symptom and ENS symptom. The CNS symptoms include analgesia, nausea, vomiting, sedation, euphoria, and dizziness. ENS means enteric nervous system symptoms like decreased motility, decreased pyloric tone, inhibition of intestinal contraction, increased absorption of fluid and electrolyte, and increased anal tone. So the toxidrome presentation of opioid, you can remember with CPR, 3H in CPR. That is, C is for coma, P for pinpoint people, R for respiratory depression, H for hypotension, and another second H for hypothermia, and the third H for hyporeflexia. So while managing an opioid overdose, consider an opiate overdose when assessing an elderly patient with altered mental status, because PAV is prescribed particularly for opiate for pain control. And also like they will take more and more drugs. There's an increasing pain and confusion which cause an accidental overdose. And the treatment of opioid overdose in pre-hospital care, particularly it is focused on supporting airway breathing and circulation, do give sectioning if required, place an oral airway and oral adjuncts if it is required, and also support ventilation with the back muscles. When approaching any kind of pre-hospital scenario in overdose, remember you have to follow the DR airway breathing circulation. D for danger, R for response, C is airway, B is breathing, and C for circulation. And considering the opioid overdose, again, even if the patient is arousable, but remember, always monitor the respiratory effort carefully. And sometimes that patient may need to be told that take a few breaths, because you try to take the because encourage the patient to take breath is on. This ensures that adequate ventilation. And another thing, considering that opioid poisoning, sometimes the sedation is exhibited by opioid overdose patients often due to two effects. One is the drug effect, and the second one is due to that carbon dioxide narcosis following respiratory depression. Both will cause that sedation and narcosis. So in the pre-hospital care management, opioid poisoning, particularly where the antidote for opioid is naloxone, is highly recommended. Even in American Heart Association, the naloxone is part of basic life support management. Coming to the cholinergic, elevated level of acetylcholine, which will cause the drug effect. One is the direct cholinergic effect, and the second one is the effect due to the inhibition of the cholinesterase enzyme, which in fact break down the acetylcholine. And the cholinergic drugs and agents include the cholinergic agents are nicotine and mushroom, and anticholinesterase drugs like organophosphorus and nerve gas. So how do you remember, what are the clinical presentation of these toxidrome? This includes salivation, lacrimation, urination, defecation, GI stress, and emesis. This easily you can remember the mnemonic sludge. And management of this overdose is included in pre-hospital care or management. You focus on ABC and vigorous monitoring, and also be prepared for seizures. And in hospital management of this organophosphorus and other cholinergic, anticholinergics management, this include like advanced airway life support, advanced life support. Atropine is the basic anticholinergic, and antidote is the polydoxin. So you can remember this in hospital management through the AAA. So while you an EMS approaching and or attending an overdose cases, you need to be remember certain things. One is ask a few points you have to always remember, which include ask the patient or relative or friends about what drugs or poison has been taken, and always remember sometimes self poisoning is there, and explore for that influence of under influence of alcohol. Sometimes patient may or may not be known about the tablet what he took. In that case, check any bottle or the packet for the name and quantities of the drug or poison which are available. Again, unconscious or a severely poisoned patient, you look for the hospital notes and the details of the previous overdose history, and record the time of ingestion for ingestion of the drug or the poison. Examine the patient all over the signs of the poisoning and the injections mark or self-injury. And also you look at for mimicking poisonings like some like non-poisoning conditions like head injury and meningitis. And remember that the traditional drugs, Chinese drugs, herbs, or Ayurvedic medicine is also sometimes it is also will cause toxins. And also you need that assessment and monitoring while approaching your patient, which you assess and record the conscious level. Observe the patient frequently, check blood glucose, particularly in patients with confusion, coma, and convulsion. Remember with the 3 C's, monitor breathing and record respiratory rate, and use a pulse oximeter is always, and do an IV exercise needed. And SpO2 sometimes may mislead you because the carbon, particularly those with carbon monoxide poisoning, and don't give oxygen those within paraquat poisoning. And continuing your assessment and monitoring, you check an ABG if available, particularly those patients with unconscious and with a breathing abnormality. Record and monitor ECG in cases of unconsciousness, tachy and bradyarrhythmia, and those taken drugs or poison which at risk for arrhythmia. Record blood pressure and temperature. And investigations particularly focus on suppose someone with paracetamol poisoning. If there is any possibility of paracetamol poisoning, measure this or send a sample and record the time of the sample on the bottle, and also put a note on that. And many labs can measure salicylate, ion, and lithium, and also paraquat if it is necessary. Now, finally, concluding this session by summarize all this and summarize that how the toxidromal approach you how to do that. Once you see a patient with overdose, you can do a focused clinical examination, which include the vitals like temperature, heart rate, blood pressure, respiratory rate, SpO2, GRBS, and pain score. Do a quick neurological examination, assessing a conscious level with ABPU scale, assess pupil and motor response. Look at for the skin moisture by particularly checking the patient axilla. Look at for the lung sound and look at for bowel sounds. Once this is there, then you decide whether your patient is having tachycardia or hypertension, tachycardia and hypertension, or bradycardia and hypotension. If there is tachycardia, is also look for agitated behavior, delirium, mydriasis, and increased temperature. If your patient is having muscle cramp, tachycardia, weakness, twitching, and fasciculation, likely that person will be a nicotine or a mushroom. If the patient, again, I'm coming back to that patient with agitation, behavior abnormality, delirium, mydriasis, etc., you again look for how the skin look like. If the skin is dry and with a decrease of bowel sound, that poisoning is likely to be anticholinergics like TCA or antipsychotics. If the patient is having sweaty and hyperactive bowel, then it is likely a sympathomimetic toxin like cocaine, amphetamine, PCP, or ephedrine. Now coming to the patients is with the bradycardia and hypertension, do his GRBS. And if GRBS is showing hypoglycemia, it is likely a beta blocker blocking, if it toxicity. If it is patients with hyperglycemia, it is likely a calcium channel blocker toxicity. And if your patient is present with a diarrhea, urination, meiosis, bronchoria, bradycardia, emesis, lacrimation, sweating, salivation, with the sludge, it is likely a cholinergic pesticide like organophosphorus or carbamide. If the patients with altered mental status and respiratory depression, if it is if it is altered mental status and respiratory depression, then you look at the pupil. If the pupil is pinpoint, it is likely opioid or clonidine poisoning. If it is pupil is normal, it is likely a sedative, hypnotics, like or it can be an ethanol poisoning or a benzodiazepine poisoning. If there is an anion gap, there is likely a toxic alcohol. And if the vision is normal, there is a vision change or a normal vision, and with an abnormal ECG, it is likely digoxin or an Olander poisoning. Finally, how will you approach all ABCD approach in a toxic scenario? Definitely, every case you have to approach airway, breathing, circulation, and disability. But in toxidromal approach, in overdose, you also look into antidote along with the A is airway and antidote, and the B is same, D, C same, but D is also, you will look into decontamination, documented data, documentation, data collection, and sometimes dialysis. This represents for D in toxicology. And E is definitely expose the patient, evaluate the patient appropriately. And also there will be G. G is represent GRBS and gastric lavage, and F for Follies for urine assessment. So always remember, by an EMS approaching a toxic scenario, always do assess the safety. Make sure that your safety is first. There's a danger response, and do essential PP in toxic cases. So thank you for your patient listening. Thank you so much.